Greetings and welcome everyone to a very different session. We are thrilled to welcome oral surgery among the disciplines that are included within Oral Pathology 360. So, oral surgery joins the ranks of oral pathology, oral medicine, oral radiology, and with that, we are now complete in our set of diagnostic and management of oral and maxillofacial diseases. It's a very great day for us, and with that, we have a very great topic, that's odontogenic keratocyst management, which you know is of great importance to everybody. And we have a very, very great speaker and a very great oral surgeon who I am personally very fond of, and that's Dr. Sujata Mohanty. With that little introduction, let me bring her in. Welcome, Dr. Mohanty.
Thank you so much, Dr. Mandana. Thanks a lot for including me in this forum. It's always very nice to be associated with you. And I have been associated with Dr. Mandana since the COVID days. I presented on mucormycosis on this forum first, and thank you so much. Thanks for inviting me. And it's a great honor for me to be the first oral surgeon on this platform to be speaking on an oral surgery topic, that is odontogenic keratocyst.
Thank you so much. It's really wonderful to have you here. So, like we had just thought about it, and currently I'm making the sessions a little more about literally about collaboration. So, I would like you to tell everyone what would be the kind of topics or your areas of interest where they can get in touch with you, or they can work with you, or basically you are interested in.
Yeah, see, we do a wide range of cases here at our center at Maulana Azad Institute of Dental Sciences, and my interests are specifically on orthognathic surgery, distraction osteogenesis, maxillofacial pathology, temporomandibular joint surgeries, and cleft orthognathic surgeries, and TMJ.
That's a very interesting and wide range. Yes, I'm sure everyone will get in touch with you. And before we go on, let me tell everyone, as promised, today is going to be one of those rare days. There have just been probably another two times where we have given certificates of attendance on the live stream. Of course, the form is on the website itself. It's a feedback form. You will have to fill it up after attending the session, and it will only come live on the website in another half an hour. So don't be alarmed if you don't find it on the website. It is not activated as yet. It will appear at 3:30, understanding that by then most of the session will be over. There is no point in having it before the session is over, and it will be on for at least half an hour after the session. You just have to go there and basically mention what you listened to, and you will get your certificate by tomorrow. Also, to as usual, to get a very good image of the slides, just see that you increase the resolution on the playback of YouTube. The standard it sets it to is a little low for text, so increase it a little bit and you will see the presentation much better. And save all your questions and all your comments, and as we go on in the lecture, you can type them in. We will respond and read all of them at the end as usual. And hello to everybody who is here, whether it's your first time or you have been here before. Welcome everyone. I can see a whole lot of colleagues already here. It's wonderful to have you here, and we will listen to the lecture and then come back for the discussion.
A very good afternoon to everyone. And thanks a lot, Dr. Mandana, for inviting me to this forum to speak on odontogenic keratosis, the most notorious of the odontogenic cysts, about my experience of 25 years and its insights and advances. So, odontogenic keratocyst was the nomenclature that was first coined by Philipson in 1956, and the characteristic features were first described by Pindborg and Hansen in 1963.
It is a dilemmatic, distinctive, odontogenic, developmental, and intraosseous cyst of epithelial origin of oral and maxillofacial region with specific characteristics like rapid infiltrative growth, aggressive nature, high recurrence rate, and defined histological features. It was known as dental cyst first by Hunter in 1774, and till now there are several nomenclatures over the years, out of which most commonly used was odontogenic keratocyst as coined by Philipson. And WHO also recognized it as a odontogenic keratocyst in 1992, but it reverted the nomenclature to keratocystic odontogenic tumor, thinking it was a benign neoplasm in the year 2005. Again, it reverted the nomenclature to odontogenic keratosis in 2017, and why it was done so, I will discuss later on. And why it is termed as a odontogenic keratocyst? Because it is odontogenic in origin, arising from the dental lamina. It is lined with parakeratin within the bone, and the cyst contains clear fluid and cheesy material resembling keratin debris. So now coming to why the WHO changed the nomenclature. In Shears, as Pinberg had said that it was odontogenic keratocyst, but WHO reverted it to KCOT in 2005 after finding out its aggressive behavior, the occasional presence of solid variant, its propensity for high recurrence, and an associated PTCH1 gene. But again, it reverted to odontogenic keratocyst after finding out that the PTCH tumor gene mutation is not only associated with odontogenic keratocyst, but other cystic lesions and non-neoplastic lesions, for example, like dentigerous cyst. And there is also resolution of the lesion following marsupialization, which is commonly seen in other cysts as well, but is not an outcome with tumors. It usually accounts for 7 to 8% of all the cysts of the jaws, occurring at all the age groups with peak incidence in second and fourth decades of life, occurs mostly in white population, and male to female ratio is 1.6 is to 1, most commonly affecting the mandible. That is, the ratio is 2 is to 1 in comparison to the maxilla. The theory of origin of OKC is twofold. 60% of it arises from the dental laminar rests or from the basal cells of the oral epithelium. So it is a primordial origin. And the remaining 40% arise from the reduced enamel epithelium of the dental follicle, that is dentigerous in origin, where the crown of the tooth or part of the tooth is present within the cyst cavity. In others, the tooth is outside that of the cavity. Mainly it is asymptomatic, but when it enlarges, it causes expansion and may cause tooth mobility as well. Pain and swelling are there when it ruptures and leaks, the keratin leaks into the surrounding tissue, resulting in an intense inflammatory response. Nerve sensation is usually not affected, although frequently it displaces the inferior alveolar neurovascular bundle along with the canal to the inferior border. Radiographically, it presents as a unilocular or multilocular radiolucency with scalloped, multilobulated, and distinct margins. Multilocular lesions represent soap bubble appearance. Unerupted tooth is involved in 25 to 40% of cases, and there is downward displacement of inferior alveolar canal. Frequently, it resolves the roots of adjacent teeth and in a smooth and regular pattern. There is lingual or buccal cortical plate perforation, or perforation can be found in both the cortical plates. The expansion of the odontogenic keratocyst is unique in the sense that it expands in an anteroposterior direction than buccolingually, in contrast to other tumors. Even though it resolves the cortex as well as the inferior border, but it is at a slower rate than the intermedullary trabecular bone. And it primarily invades the marrow. When maxilla is involved, there is greater buccal expansion than the palatal expansion, if there is any expansion at all. On aspiration, it reveals keratin as a dirty, creamy white viscoid suspension, and the protein content is less than 4 grams per deciliter, as the keratin is not a soluble protein. Histologically, it has two variants, the parakeratinized and orthokeratinized. In the parakeratinized variant, there is presence of parakeratin. The basal cell layer has palisaded columnar cuboidal cells with reversely polarized nuclei, giving it a picket fence or tombstone appearance. There is corrugated appearance of the luminal surface or parakeratotic epithelial cells. There is presence of small daughter cysts or satellite cysts in the connective tissue wall adjacent to the epithelium, and sometimes they can also be found in the adjacent overlying bone as well as the oral mucosa. In the orthokeratinized variant, the basal cells are flat or low cuboidal and are not hyperchromatic or palisaded. In addition, satellite cysts are also not present. These can be found in association with syndromes like nevoid basal cell carcinoma syndrome and Noonan syndrome, along with other features. And in these syndromes, they are present in multiple sites. The features of these syndromes are bifid rib, calcification of the fag cerebri, there is hypertelorism, frontal bossing, palmar plantar pits, then multiple nevi, etc. So along with that, you can find multiple odontogenic keratocysts at multiple sites in the mandible as well as in the maxilla. The odontogenic keratocyst, as described in shear, has a very high recurrence rate because it has a very thin lining which is friable, and portions of it are easily left behind during enucleation or curettage. The daughter cysts occur beyond the visible margin of the lesion into the connective tissue, bone, or the overlying mucosa, and some of these lesions may also originate from the oral mucosa. So even if we are treating the bony lesion that has extended into the bone, we are leaving behind some amount of tissue in the oral mucosa, resulting in recurrence. The investigations which are required to come to a diagnosis of odontogenic keratocysts are clinical examination, radiographs, OPG, NCCT or CBCT. NCCT and CBCT are more important in determining the extent of the odontogenic keratocyst if there is and also to diagnose if there is any perforation and involvement of the overlying tissues. Aspiration is done to evaluate the protein content, and biopsy to diagnose the odontogenic keratocyst. In our center, I have taken up a study on the odontogenic keratocyst, which were managed over the past 25 years by various methods with a minimum of 5 years of follow-up. The assessment included demographic data, pre-treatment clinical and radiographic pictures, treatment strategies employed, need for resurgery and recurrence. A routine follow-up protocol was employed with clinical assessments at 1 week, 1, 3, 6 months post-operatively, and every 6 months thereafter. Radiographic assessment was done every 6 monthly. Based on the clinical and radiographic assessment, the lesions were again classified into following the treatment, they were classified into complete resolution, where entirely obliterated cystic cavities were found with complete osseous healing after conservative procedures, and the procedures I'll be describing subsequently. Partial resolution or residual defects were the lesions that failed to ossify completely with persisting residual cavities. Recurrence means there is presence of new lesions which arise in the completely resolved sites. The records of a total of 192 patients with 244 involved sites were found that were treated surgically for histopathologically diagnosed odontogenic keratocysts, but out of these, 26 patients with 40 sites were lost to follow-up within 5 years of treatment. So they were not included in the study. So making it 166 subjects with 204 sites, which were included in the study for analysis. These patients were in the age group of 4 to 72 years of age, and the male to female ratio was 2.5 to 1, which is at a higher range than as what is reported in literature. 10 of the 166 patients were diagnosed with nevoid basal cell carcinoma syndromes. The ratio of involvement of maxilla to mandible with respect to these sites, where 1 is to 4.5, which is also higher as compared to what is reported in literature. And of these sites, 167 were found in the mandible and 37 in the maxilla. Out of these, again, 15 were in the anterior mandible and 152 in the posterior mandible, 15 in the anterior and 22 in the posterior maxilla. 49 of these lesions were multilocular. Two of the cases were associated with cutaneous perforation, one with trismus, one case with a mandibular body fracture, and two with mental nerve paresthesia. And there were several cases which were associated with mucosal perforation as well. Histopathological evaluation revealed that 185 lesions were parakeratinized and 19 were orthokeratinized. All the 33 lesions seen in the 10 syndromic patients were parakeratinized OKCs. The follow-up period ranged from 60 months to 125 months. The goal of the treatment were to completely eradicate the lesion, to complete the healing of the defect, to prevent the recurrence, and a long-term follow-up. Coming to the treatment modalities that were used by me in the last 25 years, they were divided into conservative and radical management. The conservative management included decompression or marsupialization with open packing with iodoform gauze bath, enucleation and curettage. These two options were used prior to 2005 and not used anymore alone. They are used in conjunction with enucleation and chemical cauterization with either carnoid solution or enucleation with peripheral ostectomy or enucleation and chemical cauterization plus peripheral ostectomy. Enucleation with chemotherapy using 5-fluorouracil after the year 2018 is also being used. Radical management included marginal resection or segmental resection depending on the size and characteristic of the lesion. Unilocular ones with intact cortical margins and no communication with sinonasal mucosa and proximity to the neurovascular bundle were treated by enucleation as mentioned and primary closure prior to 2005, but due to its high recurrence rate of 60%, it was then augmented with peripheral ostectomy or chemical cauterization with carnoid solution. Chemical cauterization only where the residual osseous walls were thin, and it was again peripheral ostectomy was used along with enucleation and chemical cauterization where the bony walls of the cysts were thick. From 2018, 5-fluorouracil is also used as an adjunctive alternative to carnoid solution after enucleation. And 6 of the patients have completed the 5-year follow-up. 5-fluorouracil is packed in the cystic cavity after enucleation and was removed after 24 hours. A radiographic assessment was done every 6 months to evaluate the osseous healing and recurrence. In cases with residual lesions persisting beyond 1 year, they are called residual lesions, and those recurring after primary conservative surgeries, that is arising in completely healed areas, a treatment of enucleation with carnoid solution and peripheral ostectomy was subsequently performed, and this is also a modified dredging. And these lesions which recur or are or residual in nature, they are usually smaller in size than the initial lesion, much smaller in size. All the teeth adjacent to the lesion underwent vitality testing and were addressed endodontically if found to be non-vital. Teeth associated with root resorption or bone loss were extracted. Larger lesions with cortical perforation, sinonasal communications, or multilocularity, decompression or marsupialization was performed after creating a window into the cystic cavity, evacuating the contents, and making it a unilocular cavity by breaking the locules. It is followed by placing iodoform dressings or by placement of a decompression plate with plastic stents or rubber stents. The dressing was changed every 7 to 10 days until the lesion either underwent complete resolution or until 1 year post-surgical visit, whichever was earlier, and the stents were also reduced in size in subsequent visits. A segmental or marginal resection was performed for 6 of the cases, which were associated with multiple cutaneous or mucosal perforations, multilocular lesions involving the ramus condyle unit with cutaneous involvement, multiple cortical perforations with severe bone resorption or pathological fracture. The resection was done with 0.5 centimeter margins of healthy bone, and excision of overlying mucosa and skin was done. Of the 204 sites surgically treated odontogenic keratocysts, complete resolution was found in 150 sites, while 46 of the lesions showed partial resolution. 32 sites out of these 150 sites that were completely resolved were associated again with a recurrence of the lesion that comes to be 20.6%. The histopathological reports of recurrence cases revealed a same parent histological subtype in recurrence cases, and the partial resolution cases either showed the histological subtype of the parent case or a complete healing that represents fibrous tissue or oral mucosa without any trace of the without any trace of the histopathology of odontogenic keratocyst. One case of resolved lesion resulted in primary intraosseous carcinoma, which was addressed by resection and neck dissection elsewhere. Among conservative techniques, the greatest rate of overall complete resolution was seen in cases treated with enucleation, carnoid solution, and peripheral ostectomy, and the lowest was found in simple enucleation procedures, that was 40%, whereas the recurrence was 60% with enucleation. Recurrence rates after other conservative surgeries were much lower, within the range of 4 to 12%, with enucleation, chemical cauterization, and peripheral ostectomy showing the lowest overall recurrence rate of 3.7%. The 6 cases that were treated with segmental or marginal resection were all completely resolved with no observed recurrences even after 5 years. When we observed the outcomes of treatment of parakeratinized syndromic OKCs and non-syndromic odontogenic keratosis, it was found out that the procedure of enucleation with chemical cauterization and peripheral ostectomy resulted in the lowest rate of recurrence. And the shortest recurrence period was seen following enucleation, and longest time of recurrence was seen in decompression group. For orthokeratinized cysts, they were all treated by conservative methods by marsupialization or enucleation with carnoid solution, and they resulted in complete resolution with no recurrence till date. So, the odontogenic keratocyst has been infamous for its aggressive behavior and a proclivity for recurrence. Consequently, contemporary recurrence rate for this lesion ranged from 9 to 62.5% following enucleation, as reported by Morgan et al. And similar results were found in our study, that was 60%. Adding a peripheral ostectomy to enucleation reduced the overall recurrence rate to 26.7%. In cases where chemical cauterization was only done with carnoid solution after enucleation, an overall 17.4% recurrence was observed. Morgan et al. Reported a significantly higher rate of 50% with this modality, but our results showed a low recurrence rate with chemical enucleation and chemical cauterization only. To overcome this issue, a combination of enucleation and chemical cauterization with carnoid solution and peripheral ostectomy has been suggested, and this procedure brought our overall recurrence rate down to 3.7%. Some authors have found excellent results with even lesser invasive techniques like decompression or marsupialization with or without secondary cystectomy. Pogrel et al. Found a complete resolution and a 0% recurrence at 1.8 to 4.8 years of follow-up. But in my opinion, this time period of follow-up is less for OKCs because recurrences have been found even till 10 years after treatment. So at least 10 years of follow-up is required for odontogenic keratocyst cases. They believe that marsupialization causes either metaplastic changes in the lining of the OKC or there is gripping substitution of the cystic cells with cells of normal oral mucosa over a period of time. In our current series of patients, the recurrence rate with marsupialization and decompression was higher with both kinds of parakeratinized cyst, that is syndromic and non-syndromic, as compared to 0% in orthokeratinized cysts. Radical management strategies for the OKC are advocated as the primary modality of treatment by a number of surgeons on the basis of its aggressive nature and its great tendency for recurrence. Nearly all the studies have indicated a 0% recurrence rate after resection of the lesion, and this is also our finding. OKCs associated with NBCCs are considered a more recurrent and aggressive variant as compared to sporadic OKCs. The overall recurrence rate of syndromic OKCs in the current study was 20%, which was higher than in non-syndromic group. And this non-syndromic group was 17%, because we have taken into account the group of enucleation and curettage also, which we are not using anymore. So if we would have dropped this group, then our overall recurrence rate would have even much lesser. Orthokeratinized odontogenic keratocyst is considered an entity which is altogether different from the parakeratinized form, both clinically and histologically, with a significantly lower recurrence rate. The limitation of our study was that the number of patients in each group was relatively small. Thus, the results cannot be generalized to all the patients. Limited number of patients were followed up to 10 years. This is the proposed treatment algorithm for the management of odontogenic keratocyst in the form of a flowchart, which we have already discussed. Coming to some of the representative cases of odontogenic keratocyst, which were treated by different modalities. This was a patient who reported to us with multiple one or two intraoral draining sinuses and mobility of teeth. There was nothing found extraorally. So this on orthopantomogram, there was a multilocular radiolucency extending from lower right 6 till lower left ramus region, involving the body and the part of the ramus of the mandible. And this patient was treated with extraction of the involved teeth, which were mobile and also showed resorption and were non-vital. After extraction, primary closure was done, except in places where we were going to place an acrylic splint with stents to keep the cavity decompressed. You can see the picture of the acrylic plate with stents. And this was his post-operative clinical healing and radiographic complete healing. Another case where on the radiograph, it showed a multilocular radiolucency with impacted tooth at the lower border and anteroposterior expansion. There is mild buccolingual expansion as well, but there was no perforation. So this patient was treated with marsupialization and open packing initially with iodoform gauze pack, and serial radiographs were taken at 6 monthly intervals. And you can see on the sequential radiograph that the third molar has come up, has erupted halfway. And now it was already 1 year follow-up. So now it was planned for extraction of 8 and go for enucleation, chemical cauterization and peripheral ostectomy of the residual lesion. And the last radiograph shows complete healing or complete osseous healing of the lesion. This was another patient which presented with a buccal expansion on the left side of the mandible. And you can very well appreciate the presence of buccal expansion, and there was also multiple sinuses present which had healed subsequently. On radiograph, you can appreciate, on CT scan, you can appreciate the resorption of the buccal cortical plate, and it was also soft to palpate. That means there was loss of the buccal cortical plate. It had expanded into the soft tissues. So it was treated with marginal resection because more than 1 centimeter of healthy bone was present at the lower border of the mandible. So we preserved it and we removed we did a marginal resection of the lesion involving the teeth, and also the buccal mucosa was also excised along the lesion, as you can find in the third diagram. This was the clinical healing of the photographs showing clinical healing, and a very good amount of lower border of the mandible at the 5-year follow-up. You can see that. Another patient which presented to us with multiple draining sinuses intraorally and extraorally and multiple mobile teeth. And on the photograph, you can see multiple draining sinuses over the angle of the mandible and preoperative radiographs showing a multilocular lesion extending from the canine of right side till the angle of the mandible on the left side with resorption of the roots and bone loss. So this was treated with segmental resection, and reconstruction was done with a reconstruction plate. The multiple sinuses in the skin were addressed by excision, and reconstruction was done with a occipital flap, showing very good healing. Another case which reported to us some 10 years back, and there was involvement, the patient only had mobile teeth and multiple intraoral sinuses, and his OPG revealed the presence of a multilocular radiolucency extending from ramus condyle unit of one side involving the whole of the dentate segment till the ramus condyle unit of the other side. A decompression plate was given to this patient, and he ended up with complete healing with you can also see the presence of the inferior alveolar neurovascular canal, inferior alveolar canal on both the sides. But again, he ended up with some recurrences in multiple areas, three areas, which were very small in size and were subsequently managed by enucleation, chemical cauterization, and peripheral ostectomy, and those were also healed. But on his 8-year OPG and CT scan, he reported with swelling at 8 years of follow-up with the radiographic evidence of radiolucent lesions in the mandible. So thinking that it was again recurrence of the odontogenic keratocyst, complete excision of the lesion with peripheral ostectomy and chemical cauterization was done after enucleation of the lesion, after removal of whatever pathology was there. But we got a solid mass of tissue from the left side of the ramus region, which was sent for, and whole of the tissue was sent for biopsy. And on biopsy, it came out to be primary intraosseous carcinoma, showing all of its features. Thus, the patient underwent resection of the lesion with neck dissection elsewhere, but the patient passed away after 2 years of this surgery. And this case we reported in the Journal of Oral Surgery, Oral Medicine, Oral Pathology, and Oral Radiology recently, which was published in their February issue. Coming to recent advances, the use of 5-fluorouracil has revolutionized the treatment of odontogenic keratocysts. 5-fluorouracil is an antimetabolite drug which inhibits thiamidylate synthetase, which is required for DNA synthesis, causing cell death. It is used as an adjunct in the management of OKC. The advantages are that it is technically simple, it is of low cost, decreased operating time, reduced morbidity with minimal nerve injuries, and inhibition of recurrence. This was another case which with not much clinical presentation can be seen, but on radiograph, you can appreciate the presence of a unilocular radiolucency on the right side of the ramus of the mandible. And this patient was treated with enucleation, peripheral ostectomy, and application of 5-fluorouracil in a gauze pack, and it was sutured in place for 24 hours and removed after 24 hours, and primary closure was done. So you can see the OPG immediately after surgery and post-operative radiographs showing complete resolution after application of after enucleation and application of the fly fluoro USA. So there were some recent advances for molecular and genetic insights into the behavior of the odontogenic keratocysts. Markers are developed for early detection, and research is going on into specific biomarkers that could allow for early detection and better monitoring of recurrence. Ki67 overexpression in OKCs can be used to assess the aggressiveness of the lesion. Some epithelial mesenchymal transition markers, such as E-cadherin and N-cadherin, involved in this epithelial mesenchymal transitions, can also be used to determine the progression and metastasis of OKCs. Coming to future trends, understanding the PTCH1 gene mutation is important because OKCs are often associated with mutations in the PTCH1 gene, which is a part of the hedgehog signaling pathway. So targeting this pathway with specific inhibitors like vismodegib and sonidegib could provide new therapeutic avenues for treatment of OKCs. Studies have identified that BRAF V600E mutations are seen in some OKCs. So targeted therapy with the vemurafenib and dabrafenib agents against this mutation can be used potentially for treatment of OKCs as used in other cancers. So this the surgical management of odontogenic keratocyst was published in International Journal of Maxillofacial Surgery in 2021. But at that time, the minimum follow-up of 5 years were completed up to December 2019. Now another 5 years has been added to this 20 years of experience, making it 25 years of treatment of odontogenic keratocyst. So what are our take-home messages? OKCs, although a notoriously recurrent and aggressive lesion, it is still a benign pathology and responds favorably to conservative surgical approaches in most of the cases. Radical surgery, even in large multilocular cysts, would represent an overkill or overtreatment, and such surgeries must be reserved for unresponsive and or complicated lesions, like when they have when there is a pathological fracture, or when the overlying soft tissues have been involved. The follow-up should be at least for 10 years.
That was a very interesting and very thorough lecture, I must say. It really covered so much. Thank you, Dr. Mohanty. That was really nice.
Thank you. Thanks for the invitation, Dr. Mandana.
You're most welcome. That was a very, very interesting and very thorough work, I must say. It's so rare to come across such meticulous, long-term studies. It was a pleasure to watch and a pleasure to listen to. And we have someone requesting for the link to those studies. So afterwards, if you share with me those links, I will put them in the description of the video.
Okay.
Right. Now we have already some questions, but I have some amount of information to share. So I will share those. By the time everyone, please put in the rest of your questions and comments. I can see we have lots of friends today with us, lots of dear friends in the audience. Nice to have all of you here. I will just share these bits of information with you all and then we come back. First and foremost is, as you know, we celebrate our individuals who join us in our what is it called, in our community. So we have a new member, Dr. Devashish Bhattacharya has joined us. Thank you so much for joining us. You can also join us. There's a join button right under the video, and what that does is it takes you to a place where you can choose the level of your membership. There are three: enthusiast, expert, and maestro. So you already can see a number of our members are in the audience, and you can see that their names are different. There is a different color 360 in front of their name that tells you just how long they have been members. The main thing about this is that it basically supports us in the additional work that we want to do among those being the video atlas of oral and maxillofacial diseases that we are preparing. So your support really helps us, and there is a number of benefits that you get. It's a small amount. You can choose how much you want to pay, and you can also cancel at any time. So it's not a commitment for life. Anyways, just go through it. If it's something you would like to do, please, it will be helpful. Another thing is our upcoming open mic contest. So this, of course, you have been, I think everyone has been hearing, but just to tell you, it is both for faculty and for students. So anyone who is not a student is a faculty. So whether it is BDS, MDS, a master's, a PhD, it all students. It's all goes into the students category. And anyone, whether in academics, organizational, or private practice, who is not studying goes in faculty. It was, for the want of a better word, I used faculty. So, and it is open to anybody within the healthcare scenario, anyone within the healthcare system who has an interest in the oral and maxillofacial diseases. There's a number of things where the both the contests are there. It's you make a 5 minute live presentation, and for the students, the student and one guide or supervisor, if you have a teacher helping you, will get the certificate. For the faculty, everybody gets a certificate for participation. The winners for the student will competition, the winner gets, basically, besides of course certificates, but will also, the three winners gets certificates in both the contests. But in the student one, the main winner, the first prize goes to the person who is the chosen by a combination of the audience vote and experts who will be judging. And also, that person gets to give us a video of their choice to be featured on the channel. For the faculty, well, whoever wins will get a chance to present on OP Tuesdays a live lecture of their choice, and also three winners that we will be conducting this three times during the year. The three winners will have a contest against each other sometime in March, and one of them will be a guest speaker as the rising star speaker for our upcoming International Oral Diseases Case Presentation Conference 2025 in May. That is about the contest. If you scan this, you will find everything else you need to know about it. And yep, that was all the news I had for you. Let's come back and on with the discussion. Yes. So let's see what are the questions we have here. Let me start from the beginning. And yes, there are lots of hellos from everybody. Hello back to you.
Hello.
And question. Yes, we got a question. Okay. This is from Dr. Priya NS. Hi, Priya. Well, is there any variation in the aggressive behavior of OKC involving pediatric population and adults?
OKC in pediatric population is very, very less as compared to the adults, because mostly it affects the age group of from second to fourth decades of life. And in children, it is very, very rare. And when it happens in children, it is very small, and mostly it is diagnosed during routine radiographic checkups. So I don't think it is very aggressive in pediatric population, and this kind of population, OKC affecting pediatric population is very, very less. Or
Thank you.
they are not diagnosed at the time during childhood, and they are diagnosed during adulthood, when there is some complication, or during routine radiographic checkups.
That was a very good point. Yes, good question and a very good answer.
Yeah, good
Another one
question.
let me see, is this a question? Yeah. Okay. We have one from Dr. Bhuvan Nagpal. He's saying, nice presentation, ma'am. Great
Thank
study.
you.
I wanted to ask that in your experience, which cases have high recurrence rate like solitary OKC or NBCC syndrome? Oops, we lost Dr. Mohanty for the moment. She'll be back. These are the problems of, well, an online meeting. So, in the meanwhile, just to remind everybody, the form has gone live on the website, but I do request everyone who wants the certificate to please at least put in a hi and your name here. Just say hi, and in case you're like, for example, we have a friend here who is fun with learning dentistry. Now I have no way of knowing who that is. So please put your name in. Of course, if your name is your YouTube ID, then that is fine, no problem. So just
Of
everyone
them
get
in
that
one
going
session.
till Dr. Mohanty comes back. Yes, she's back. Yes, over to you, Dr. Mohanty.
Yeah, I have already answered this question.
You have? Okay. You
Can
have.
you
Okay.
hear me? When you are
Yeah,
you
I
are
can
not
hear you.
audible, Dr.
You were
Mandana.
lost for a few seconds. You were lost for a minute, actually.
Okay,
Okay.
okay. Then the solitary OKC has a lower recurrence rate than NBCC syndrome, as already discussed. Am I audible?
Yes, now you are audible. Yes.
Am
We
I
basically
audible?
just. Yes, yes, you are. Can you hear me?
Can you hear me?
I can. Yes.
Hello? Can you hear
Yes.
me?
Yes, I can.
Hello?
Let me put a chat.
Your voice is breaking, Dr. Mandana. Can you hear me? I can't hear anything.
Can
Hello?
can
Can you
you
hear me?
see chat? Hello.
Your voice is breaking. Your voice is breaking. Am I audible?
You are audible. You are audible. One
Am I
second,
audible?
everyone. Let me send Dr. Sujata a message.
I have lost your voice. I can't hear anything. Hello?
Yes, I can hear you. All right, one second. There is another way of doing this.
You hear me? Okay. The solitary OKCs
Okay.
usually have a lower recurrence rate than NBCC syndrome anytime because there are multiple of them, one or two, they definitely recur over a period of time. And the NBCC syndrome, as already discussed, the solitary OKCs, even if the treatment modality remains the same except for resection, there is definitely higher recurrence rate in NBCC syndrome of the odontogenic keratocyst as compared to solitary OKCs.
Okay. There is another one from Dr. Bhuvan. Is malignant transformation rate of OKC. Okay, we have lost Dr. Sujata again. Let me see the question into SCC. In your experience, then can patch mutation genetic testing practically done as a preventive predisposer for the patient? Dr. Sujata, are you back?
Yeah, yeah, I am back. I'm sorry,
Okay,
I lost
no
my
problem.
connection from the desktop. Now I am on the laptop.
No problem. Okay, we have another question for you. So, malignant transformation rate of OKC into SCC. In your experience, can patch mutation genetic testing practically be done as a preventive predisposer for the patient? As a predictor, I guess, as a preventive predictor for the
Yeah, as
patient.
a preventive, not predisposer. Yeah, it would be predictor for the patient. See, I don't have any experience on genetic testing because we don't have that facility in our place. And we have seen only one malignant transformation in odontogenic keratosis because we followed it up for a longer period. That the patient which I had shown earlier, it was a very big odontogenic keratocyst, starting from one ramus condyle unit till the other ramus condyle unit, involving the whole of the mandible. It was multilocular. So it was treated, we treated it with decompression after making it into a one cavity. Then we had given him a decompression plate where where stents, rubber stents were incorporated to keep it decompressed. And the decompression stents were reduced in size over a period of time, and there was complete healing. He was perfectly fine till 3 or 4 years of treatment. After that, he again developed there was recurrence of the odontogenic keratocysts in 2 or 3 places, which were very small in size as compared to the very big initial lesion, which was which was treated with enucleation, chemical cauterization with carnoy solution. At that time, we were using the original carnoy solution that contained chloroform also, and peripheral ostectomy, and the patient was fine. Again, when he came back at 8 years of follow up, he had a complaint of swelling of the lower face. And so, when we examined, there was nothing intraorally but some expansion on the left side of the angle of the mandible. We went for a CT scan, OPG and CT scan, and there was radiolucency, multiple radiolucency with a larger one on the left side of the angle region. So we thought it would be a recurrence of the lesions. So we wanted to enucleate it again and submit the whole of the tissue for histopathological examination. When we did it, it came out to be a primary intraosseous carcinoma. So that was the only case which I don't know whether the OKC had transformed into carcinoma, or it was a carcinoma on its own. That I don't know. And genetic testing, I have no idea about it. I have no experience in it because it's not available at our center right now.
Yes, it would be interesting to test once genetic testing becomes available. I don't know if this is practical or possible, but it would be interesting to test the original tissue and the cancer,
Yeah,
this
but then
squamous cell
I think
carcinoma.
I think it would be very, very expensive. The genetic testing
Yes,
is, the labs are very limited, and it is a very costly affair.
yes, yes. Maybe if you get a grant to do it,
Yeah,
to see if it is connected. This is not something you can expect the patient to
yeah,
pay, of course. This
exactly,
is
exactly.
entirely for what I would say academic purposes. Yes. Okay, then we have a lot of everyone complimenting the lecture, which is definitely true. Let me see, there is one more question. Dr. GK. Okay. Excellent, ma'am. Conversion of OKC to KCOT and KCOT to OKC. Any articles or any thoughts on that?
Uh, I have the WHO thing. WHO had reverted the OKC to KCOT, then KCA2 to OKC. I don't exactly remember. I'll definitely revert back on this.
Yes. Okay, then who, what else? Do we have any other questions? We have the second, same question that Dr. I told you we had a question on it from our regular, one of our regulars. Dr. Hilla had asked me to ask you that question because he's not able to attend. And there you go, someone else has asked too. So, use of cryotherapy in OKC and safe dose of 5-FU for OKC.
See, cryotherapy we used only in two patients for the treatment of OKC. They have not yet completed the 5 years follow up. But then in one patient, he ended up in having multiple allergic reactions in the skin. So I don't prefer using cryotherapy in OKCs. Thus, coming to the safe dose of 5-fluorouracil, the 5-fluorouracil is used only once, and it is soaked in a gauze. It's cost effective, and then it is removed after 24 hours. You do not use it again and again, so it is completely safe to use 5-fluorouracil as a topical agent. It's not a systemic agent.
Uh, when we were discussing, and I'm sorry if you did say it in the lecture and I sort of missed it, is you were talking about the Carnoy solution and how it is now different. Would
Yeah,
you like to
the
cover that?
original, yeah, definitely. The original Carnoy solution, which contained glacial acetic acid, absolute alcohol, chloroform, and ferric chloride in a ratio of 1 is to 3 is to 6 is to 1. And the main role of chloroform was to fix the tissues. And nowadays the chloroform, the use of chloroform is banned and it is not available, so this solution is now called a modified Carnoy solution without the chloroform. But the efficacy of this is not as compared to what it was with the original Carnoy solution. There was delayed healing, there were recurrences, so I don't use modified Carnoy solution. So I have started use 5 fluorouracil instead of Carnoy solution, and it is very cost effective. It is a one time affair, and it does not result in nerve damage or paresthesia of inferior alveolar nerve if it is exposed. Then if you are using Carnoy solution, definitely there will be paresthesia for some time. It is not, it is a temporary paresthesia. So with 5 fluorouracil it is not the case.
Yes.
And as I said, there is, I don't know whether there is any article or not, but you can find it on the WHO manual, the conversion of OKC to KCOT and KCOT to OKC. OKC to KCOT in the year 2005, and again KCOT to OKC again in the year 2017, because OKC heals with marsupialization also as compared to other cysts, but which is not a feature of tumors. And also the PTCH gene, which is found with OKC, it is found in association with other cysts like dentigerous cyst as well, as with other tumors. So the WHO reverted the nomenclature to OKC again in 2017 to from KCOT. So you'll find it in WHO manual.
Thank God for that. It was one of those things which one was not really happy about, that change. So we're glad that it came back to being
Yeah,
OKC.
we were also not happy because see, OKC, even though it is very aggressive, it has high recurrence rate. Still, it is a benign lesion. So
Yes. And the minute you call something
otherwise,
a tumor, that entire thing changes. The
yeah, entire
entire
thing changes. You
perception
have to
changes.
go
Yes.
for resection with
Yes.
at least zero point 0.5 centimeter of safe margins. And for
That's so
OKCs, complicated OKCs, you save that the more aggressive or more invasive surgeries are saved for the last in case of
yes.
complicated cases.
True. We have one more. Uh, 5-FU cream has same efficacy as injection.
It's not an injection, it is available in the injection form. We use that injection form. I have not used sorry, I have not used the injection form. I have used the 5 fluorouracil cream form that is soaked in the gauze. It's not the injection form.
Okay. Yes, I think we are almost on time and we had a very interesting and very thorough discussion. So let me just say thank you by sharing your certificate.
Thank you so much. Thanks for the invitation and thanks for the participation. Thank you,
You're most
participants.
welcome. Yes, I have to say thanks to the participants. That was good interaction. And thank you again for being here with us. And I do hope you will come back soon. So thank you so much.
Thank you. Thanks, Dr. Mandan. Thanks.
You're most welcome. And everyone, don't go anywhere. We have to share what is happening next week, and then I have to share the link with you all for your certificate. So, the next OP Tuesdays is going to be on tobacco cessation by Dr. Aruna DS, and she is a specialist on tobacco cessation. So, it's going to be, well, on tobacco cessation. And after that, we have an interactive journal club. This is also already there on the channel, so you can see this, and you can put a reminder. The next interactive journal club is on the 20th. It's at 10:30 in the morning, our time, India time, and it's about adenoid ameloblastoma and its comparison with dentinogenic ghost cell. Now let me share with you all the link. Sorry, Dr. GK, I think we have lost Dr. Sujata again. I will ask her if she can respond to these. Everybody has that link. That's the link to go to. It is. Uh, I'm sorry, Dr. Basma, you will have to go to that link for the form. And it's basically, if you can't connect, use the link from here, just open the website, which is very simple: www.oralpathology360.com. In the tabs you will find events. Click on that, and today's event is the first one. You click on that again, it will take you to the event page, and as you just scroll down, you'll find the form. Thank you so much again, everyone, for being with us. And it's been wonderful, as always, having you with us. And with that, I shall say bye bye. See you all. Have a great week.